Good evening, everyone, or good morning, or good afternoon, depending on where you're tuning in from. I'm Robert Newman, President and Director of the National Humanities Center, and it's my pleasure to welcome you to our conference, A Crisis of Caring, the Humanities and Our Health. Over the last 2 years, we have faced not only the devastating effects of a new deadly pathogen, but have been confronted with multiple inadequacies and inequities that exist in healthcare. These have exacerbated the impact of COVID-19 in communities, both in the US and globally. COVID has made plain that despite remarkable advances in medical science in recent decades, there are aspects of healthcare, both at the personal and community levels, which require a deep and nuanced understanding of human diversity, socioeconomic effects, and cultural dynamics. Without these insights, serious deficits persist in our ability to care for ourselves and one another. Public health policies fall short, and suffering among those who have been historically disadvantaged is made exponentially worse. Through our events this week, we will be exploring how humanistic thinking and methods may help address persistent and complex issues in healthcare, from the clinical setting to the global stage. Before we start, though, on behalf of the National Humanities Center, I want to acknowledge our presenting sponsor, Biogen. Their support, along with that of our other sponsors, RTI International, the Burroughs Wellcome Fund, the Consortium of Humanities Centers and Institutes, Duke Health, Duke University, and the Federation of State Humanities Councils has made it possible for us to make the conference available free of charge to well over 800 participants joining us from across the United States and from 26 other countries from 5 different continents. To lead off, we're delighted to have with us Dr. Rita Charon. As both a general internist and literary scholar, Dr. Charon is widely recognized as the founder of the field of narrative medicine and has helped demonstrate the importance of the humanities and arts as tools for medical practitioners to use in understanding and treating their patients. Her work, along with that of other pioneers, is part of a surge in interest in the medical humanities and universities across the United States in the last 20 years. After receiving an MD in Harvard in 1978, Rita Charon was awarded the PhD in English at Columbia in 1999, concentrating her study on narratology and the works of Henry James. Rita Charon is professor and founding chair of the Department of Medical Humanities and Ethics and a professor of medicine at Columbia, where she also directs the Foundations of Clinical Practice faculty seminar, the Virginia Apgar Academy for Medical Educators, the Narrative and Social Medicine Scholarly Projects Concentration Track, the required and elective narrative medicine curriculum for the medical school, and Columbia Commons, Collaborating Across Professions, a medical center-wide partnership devoted to healthcare team effectiveness. Rita also inaugurated and teaches in the Master of Science in Narrative Medicine graduate program. Rita Charon's first book, Narrative Medicine, Honoring the Stories of Illness, was the first monograph in the field of narrative medicine, and she's co-authored or edited 3 other volumes on the subject. Her work has also appeared in the New England Journal of Medicine, Lancet, the Journal of the American Medical Association, the Annals of Internal Medicine, Narrative, the Henry James Review, Poetics Today, the Drama Review, Partial Answers and Literature in Medicine, among others. Rita Charon has received a Guggenheim Fellowship, a Rockefeller Foundation Bellagio residency, and research funding from the National Institutes of Health, the National Endowment for the Humanities, the American Board of Internal Medicine, the Josiah Mason Jr. Foundation, and others. In 2018, Rita Charon was chosen by the National Endowment for the Humanities to deliver the 2018 Jefferson Lecture, which was entitled To See the Suffering, the Humanities Have What Medicine Needs. Rita Charon is joined today by Professor Jane Thrailkill, who is a fellow this year at the National Humanities Center. Professor Thrailkill teaches American Literature and Health Humanities in the Department of English and Comparative Literature at the University of North Carolina at Chapel Hill, where her research focuses on the literature of the 19th century and literary engagements with philosophy, science, medicine, and culture. She also teaches in UNC's School of Medicine, co-directs UNC's Health Humanities Lab, and mentors students in UNC's Medicine, Literature, and Culture program. Jane Thrailkill's first book, Affecting Fictions, Mind, Body, and Emotion in American Literary Realism, examines the influence of pragmatist philosophy and modern neurology on the 19th century American novel. Her most recent book, Philosophical Siblings, Varieties of Playful Experience in Alice, Henry, and William James, uses different genres: Alice's personal diary, a ghost story by Henry, and a psychology lecture from William to illuminate how we make sense of the world and know the minds of people in it. Our articles at the intersections of science, philosophy, medicine, and literature have appeared in Neurology of Modernity, English Literary History, the Henry James Review, the Journal of Narrative Theory, American Literature, ALH, and Poetics Today, among others. I am so delighted Rita Charon and Jane Thrailkill have joined us to discuss the stories that emerge from health crises and how those stories help us both to cope and to prepare for crises yet to come. Please join me in welcoming Rita Charon and Jane Thrailkill.
Robert, thank you so much. And Rita Charon, thank you for being here with us and being our kickoff person for this amazing conference.
What an absolute pleasure. Listen to me, to be able to talk with the people who are coming to this symposium, who are critical and really committed to facing the crisis in care. What better could I be doing with my week?
I know, fantastic, I must say. You also, I think, could discern a shared interest of Rita and me, which is Henry James. I'm going to ask her about Henry James in 1 second. I just want to say hello to the audience who are coming to us from countries around the world, which is fantastic. And this is being recorded on YouTube, so it'll be available. Rita and I will talk for about 50 minutes until 8 p.m. Eastern Standard Time, at which point we are going to open it up wide for your questions, but please feel free along the way to put your questions in the chat. So Rita, why Henry James? What drew you? Here you are, a clinician, you're in New York, you're training to be a medical practitioner, and yet Henry James, and I hear from Priscilla Wald, Gertrude Stein came into your life as important interlocutors. Could you talk to us about that?
Mm-hmm. So I didn't know how to read. I was like a biology major in college, and I loved to read. I did it all the time, but I didn't know how. And I had a period of time where I would read a novel that I didn't understand, and I would run to the bookstore and say, maybe some smart person wrote something about, Absalom. Literally, I was like on my own reading theory. I had no idea. So I'm on my way to a week at the beach, and I pass by a pile of books on the sidewalk that somebody had thrown away. And I said, oh, I didn't bring enough to read. And I picked one up from the pile because it was a nice hardcover book in good shape. And it was Wings of the Dove. And I didn't even know, was Henry the psychologist or the novelist? I wasn't really sure. And I get to where I'm going, and I inhale that book in like 3 days. And I said, I didn't know anybody could write like this. And what it was that had me so riveted was his capacity to do now what I think we're all trying to carry forth, which is to understand, to intuit, to imagine, to come close to what the other is going through. What is that other going through? And boy, have I read a lot of him and many, many others by now, but he still is the master of that, not just multi-perspective work, not just free and direct discourse and all the manifestations of it, but also, George Butte put this very well, the real intersubjective contact whereby two persons become one.
Mhm.
And if that's not a model for what's needed in the face of suffering, I don't know what is.
Yeah, intersubjectivity. It's so important to your work in narrative medicine. Henry James is perhaps one of the masters of portraying in dialogue that kind of
Yes, yes.
intersubjectivity.
When you're bringing James to people who aren't used to reading him,
Mhm,
they say, I don't know, I don't know, I don't even know who's the he. Is the
mhm,
he the who's the he? And I say, James wouldn't have made it ambiguous unless he wanted it to be ambiguous. So it could be Lambert Strather. It could be, and they gradually get to understand how invested you have to be as a reader in the text. And of course, James repays your investment. Not all books repay that kind of investment, but he never fails to repay that investment. Um, yes, he has lapses and hazards and all kinds of pitfalls that people in any particular era will fall into. I recently was rereading American Scene, and I'm saying, oh, but um, but the capacity to not only imagine, put into motion, and then unite consciousnesses while you watch is extraordinary and expands the life of the reader.
yeah.
Because you say, maybe I can do that too.
So with that in mind,
Whoop, I'm not hearing you, Jane.
oh, can you hear me now? Yeah. With
Hey,
that in mind, Rita, I would love, you are in New York. You were in New York at the beginning of the pandemic. I wonder if you could reflect back on that time, 2020, April. We were all waiting, watching New York. What was that experience like? How were your patients managing both this impending crisis and how did you care for them in the
yeah,
midst of it?
yeah. Um, New York was transformed.
Mhm.
It was altogether transformed. Um, I live in the village. I live on Ninth Street and Fifth Avenue, which, not by accident, was James's favorite corner
Mm,
in Manhattan. So I'm right in the middle of the village. And there was no one on the streets.
mhm.
You would go into the grocery store, and there would be frightened looking people all masked up at the cashiers. They were there, but it was very frightening for them. Um, um, the hospital was a complete, um, it was like a military installation.
Mhm.
And you couldn't see who anybody was because they all had not uniforms with their names on it, but just these swaths and swaths of stuff. I was working at the time with the palliative care doctor. I do a lot of work kind of behind the scenes, bringing narrative work to the clinicians. So I was working at that time with the palliative care doctors, with
Mhm.
the cancer center, with the medical intensive care unit, and I also met regularly with all the chairs. There's a very interesting group. The chairs of all the departments got
Mhm.
together very frequently during that time, where the surgeons would say, we had to close we had to close the operating rooms. We turned them all into intensive care units. Um, and of course, the patients who were waiting to have heart surgery or liver transplant just had to wait. But it was my colleagues who were doing the actual work in the units, on the floors, who were so devastatedly helpless. At the beginning, anyway. By now, we kind of know what to do. We've got a lot more, it's not so bad to get COVID these days, forgive me, because we know how to treat you.
Mm.
But at the beginning, all we knew how to do was put people on their bellies. Do you remember
Yeah.
that? Proning, where a lot of time was spent by the nurses and respiratory therapists and everybody turning people over onto their belly so that they could more easily be ventilated. But beyond that, we were more helpless than, the best you could do was hold your phone, hold the patient's iPhone to the bed so the patient's family could give a final goodbye.
Mm.
That was the extent of the intervention. Because
So,
families couldn't come in, patients died alone. My friends in the emergency department said, Rita, patients are dying in their chairs. They're dying in their chairs, waiting for care in the emergency room. And then I had young fellows and residents who were taking care of their professors as they died on the ventilators. So that was life at the beginning.
So one thing occurs to me as you describe the uncertainty, the helplessness, to some extent, it's almost as if the alignment that you seek in narrative medicine, the clinician-patient alignment was excruciatingly present during the pandemic, because those words that you're using are words that often characterize the experience, the direct experience of injury, disease, and mortality.
Yes, except they were not in concert,
Mm-hmm.
that the clinicians were suffering on their own and they couldn't very easily even uh, uh, comfort. There was even little comfort to give because most of the patients, of course, were being ventilated. And as soon as they were off the ventilator, either they died, and the deaths at the beginning were extraordinary, um, or they kind of went over to the other part of the hospital. And frankly, we didn't really know how to take care of them.
Yeah.
But your point is exactly right. There's suffering squared or cubed or raised to the 10th power, however high you want to put it. And yet we were all suffering alone.
Mm-hmm.
So part of our mission was to care for the clinicians,
Mm-hmm.
make sure they didn't all disappear into despair.
Yeah.
And you know that many of them did, and you know that more than the usual quotient took their lives during that time. But we had our hands full simply meeting with the oncologists who were trying to take care of their cancer patients, meeting with the MICU, medical intensive care unit staff, to help them to summon their own sense of agency and their own sense of community. That even though they couldn't see one another because they all had the masks on, they knew who one another was. And if there could be maintained, if we could blow on the embers of their community, their colleagueship, they would better survive. The one footnote to that is there were a lot of moral injuries going on that no matter what you did, it felt like the wrong thing to do. And the one doctor who kind of stepped back as they were doing a cardiac arrest code because he knew the guy was going to die anyway, and he was so terrified of bringing this virus home to his children. To this day, this haunts him, this moral injury of I wasn't brave enough to go in that room.
Wow. So Rita, you're bringing up such an important term when you say moral injury. I am struck by what you did not say, and it's a term that all of us are familiar with. It's circulated so much, and that's the term burnout. Can you talk a little bit about, from your narrative medicine and health humanities point of view, how moral injury offers an important term that how to say it, that enhances the term burnout in important ways?
Mm. So, so burnout is an old word. Maslow has been writing on that for decades and decades.
Mm-hmm.
I think it's rather a good term because it connotes that the clinician is Tinder,
Mm.
and that the clinician can be simply used up, till there's just a smoky little campfire. I think it's a lot better than the terms that have replaced it, which have sanitized it.
Mm.
Words like wellness and resilience. Do you, in your precincts, do you not talk about wellness and resilience? We have a chief wellness officer,
Right.
and we have resilience building mandated coursework. And, both of those things point to the individual clinician as the problem or the solution. And if I give you enough yoga, you'll get better from your burnout. And if only you had more resilience than you do, you would have sailed through this. And so it's my task to buff your burnout, your resilience. Well, those are faulty concepts, because the clinician who's near despair is not near despair because she's minus a few points of resilience. She's near despair because there aren't enough nurses to take care of the patients. There aren't enough transport workers to bring her patient to the CT scan, so she has to do it herself. There aren't, in the middle of the pandemic, they're not aware of how horrible it is for her to be living in a hotel room because she doesn't want to bring this home to her family. So I'm pointing to the structural aspects of what makes clinicians despair. Sorry, that was my bell. I don't know. And so the narrative work that we've doing comes into this problem in a very different way. Right at the beginning, March 2020, I said to my guys, there are things we know how to do that can help people, so let's do them. So they said, okay. And we started these public access Zooms. I'm just going to ignore it. Public access Zooms that were open to anyone who wanted to come. And we would have 100, 120 people at a time. And we would do narrative work. We would read texts. We would look at paintings or photographs. We would play some music. We would bring works of art. This is what we do. This is one of the things we do. But one of the things we do is we bring works of art to groups, to audiences, and they examine it, and they enter it, and they look at it, and they wonder about it, and they talk about it, and there's a lot of conversation. And our facilitators are very well trained, our own graduates and students, so they know how to bring people into a text or an image or a graphic novel sliver. And then after a while, we say, okay, we're going to write a little bit. And we give them a writing prompt. And everybody on this Zoom, there's 100 people on Zoom, and they all stop talking and they look down and they start writing to the prompt, which is evocative, it's expansive, it's not, an essay question.
Mhm.
I just had a group. The reason I was late coming in is I was meeting with a bunch of clinical students at Columbia, and we were reading Joe Harjo's poem, Perhaps the World Ends Here. And of course, my prompt was write about your kitchen table. So anyway, um, then then different ones of the people who come get to read what they've written to the whole group. And don't you know, we've been doing this thing since March 2020. Lots of the people come back, they keep coming back, they know one another. The whole idea was this was a way to reduce social isolation. This was a way to reduce this unspeakable fear of what was happening to us, that you are not alone.
Yeah.
It's
So
been,
narrative medicine practices a form of gathering,
yes, yes.
often with respect to a third thing, whether it's a work of art or a text,
Mm-hmm.
to enable affiliation, to
Yes,
enable
yes,
community.
yes.
I have a philosophical question that I'd like you to puzzle with me. COVID times has been a time of waiting.
Mm,
And we can, I think, say that the experience with the medical system is also a time for many of us of waiting for appointments, waiting for test results. Um, on the one hand, the pandemic had a lot of urgency. Let's get prepared. There is a militarism almost to the preparation as you're describing. And on the other hand, I think so many of us got to know the inside of our own home, our kitchen table, so much better than before.
yes.
So there's a hurry up and there was a wait. I'm wondering, do you see as a humanist, as a philosopher really, do you see this transformation in how we value our time and think about our time carrying over from the pandemic? Or do you worry that we'll fall back into our ways?
There's no falling back after this. Don't think things are going to go back to how they used to be. And I think that's very profound the way you brought those two things together. Um, there's the being in the midst of chaos and the biggest uncertainty you can imagine, um, contrasted with what might feel ordinary.
Yeah.
What might feel ordinary. Sharon Marcus is a colleague of mine, professor in the Columbia English Department. She has an essay in Critical Inquiry this month on, it's called Reading as If to Death.
Mm.
And it's a interweaving of a detailed scholarly examination of a novel, um, um, she calls it middlebrow, um, which is about a small group in Australia who are waiting for this radioactive cloud to come to them. It's a radioactive cloud that has already killed all of the residents of North America, and it's heading their way. All right? That's the story of its, and I think that the novel was called After Death, I think. Um, this is interwoven with her personal story of having lost her wife to a very rare leiomyosarcoma in her mid 40s, where she thought she had been cured and it came back. And she was in very short few months dead. So, this is the perspective from which Sharon Marcus can examine dying. And what she says is that the reading is what allows us to approach the death. Do you see? Um, she has in the novel people knowing they're going to die, keep doing what they're doing. They keep planting their tulip bulbs. They keep, bringing the kid to the playground. They keep patching the jeans for the kid as if things will continue. The farmer keeps feeding his cows. And the point is, what is there beyond ordinary life? What are we gonna do? We're just gonna keep doing what we do. I brought this text to my palliative care clinicians because I wanted them to really dig into the notion of ordinary life. And I'm pleading with them, you don't really have to make every patient sign their advance directive about who's going to take me off my ventilator when I tell them to. Instead, let's move over into saying what makes for a good day. A good day may be sitting on the porch with your dog, and that's what we want to be doing as we approach death.
Yeah. That's beautiful. What makes for a good day? It's funny. I love it partly because I expected you to say what makes for a good death. And we talk a lot about that as if it's a very small, almost a procedure at the end of life.
Yeah, really.
Right. And you and Sharon Marcus in literature in general reminds us that it takes us in scale from the small to the large.
Yes. And in the small is the large.
Yeah.
In the small is the large, the nano to the meta. Indeed.
Yeah. Emily Dickinson's poetry is a very compressed version of going from small to the large.
Yes.
So I want to probe you a little bit about what we've learned in the pandemic about care. I want to quote Naomi Klein, who has written of what she calls, quote, the spiraling carelessness that our current system shows toward people and the planet. And it does seem to me that the pandemic, with its strange temporality of urgency and waiting, of a global problem that plays out in individual homes at individual kitchen tables as people tend their gardens or do their work. I'm wondering what you think the pandemic unwillingly has taught us about care, what caring looks like, and what is not care that we thought was care, like putting a form in front of somebody in a moment of grief.
Yeah. I feel like you're hoping that I will say something like, now that we know, comma, we won't. But I'm not sure it works that way. A lot of great stuff got invented during the pandemic. Telehealth was invented. I mean, it wasn't invented, but it that was all we had for a while. And we realized that barring some inappropriateness, patients love not having to get on the A train and go to the hospital. They didn't have to do that. And the people didn't have to spend the money to get an Uber to get someplace or walk a long distance. People with, various kinds of disabilities would find it a lot easier to stay in their living room. So that was one kind of thing. Clinicians in the hospital really, really learned how to respect what one another does. Like really in drastic ways. Like we repurposed a lot of clinicians. We didn't have enough people working in the ICU, so we took people like radiology fellows and we put them in the ICU. Go take care of these dying patients. Go manage these ventilators. They have no idea how to do that. Who taught them? The respiratory therapists. See? So what the other people know, I'm a doctor and I can say humbly and accurately that the doctors have more of this hierarchical bent than
Mhm.
others. And so for the, accomplished radiologist to be coached by a respiratory therapist was a big deal.
Yeah, so there's boundary
And that
crossing.
and
Mhm.
that has to some degree maintained. Um,
I
what?
do, Rita, could I ask, a woman named Lily, who is a scholar of Southwest Asia and North Africa, is really wanting to inquire about COVID-19 and its generational effect. So she's wondering about COVID-19 as the start of generational trauma after mass casualties. How will that resonate?
Yeah.
What do you have thoughts about that quite big question?
Well, the generations who are most at risk here are kids,
Yeah.
5-year-olds, 7-year-olds, 12-year-olds. Um, you know, I a group of my students were just talking about when COVID began. They were all seniors in college, and COVID began. Now, a senior in college is what, 22 something?
Hmm.
So that's kind of within the group I'm talking about. Um, so they said, oh, well, we're just going to give you a longer spring break. Go home
Right.
and we'll let you know when you can come back. So so they went home thinking they'd be back. And they didn't pack up and they didn't say goodbye to their roommates and they never came back.
Yeah.
So this was just completely severed. It was completely severed. These intricate, complex, maturational relationships with your college roommates, right? And it was gone. And they lost it. And, they have to pick up and make it up in some other way. The younger kids are even worse off because they didn't have school. Then they went back to school, but then they got sent back to school. And the whole thing was just so chaotic.
Yeah.
They didn't have sports. They didn't have their friends. They couldn't go roller blading, whatever. And they they were not able to recoup that.
Yeah.
And my colleagues who take care of children with mental health problems are completely swamped. There is an absolute pandemic of childhood mental illness. You all saw Andrew Solomon's piece in the New Yorker about childhood suicide. So this is like savage
Hmm.
and is the pandemic that follows the pandemic. And everybody, and it's not just in this country, everybody across the world is now some people call it the generation U, which stands for
Hmm.
uncertainty. Like,
Oh,
now what?
yeah.
Now what? And they can't trust anything. They can't trust that they'll see their teacher tomorrow. They can't trust, and it's a primordial existential uprooting. Now, I don't know if that's what Lily was referring to as generational
Hmm.
trauma, but this is one among many traumas visited by this pandemic that's not going to go away. There's no, it's not like there's even a PTSD to it. It's just TSD. There's no post to it. So
So, yeah. One thing I was going to ask you, Rita, um, the concomitant, the kind of parallel story to what you're describing is in the context of the clinic, and I see it with my medical students, a good deal of ugly feelings in the clinic. Fear,
yes, yes,
illness always brings with it, or can bring
yes,
with it,
yeah.
fear, shame, and even blame.
Hmm.
And I wonder how
Yeah.
you see the resources of narrative medicine and the arts and humanities, perhaps, helping to step in and help the adult world and people in the clinic in particular manage the ugly feelings that are really rampant right now.
Yes. Um, I thought you were going to go somewhere else. There's a lot of ugliness.
Mhm.
Uh, One of the things we have not talked about are social determinants of
Mhm.
who it is who's getting sick, getting sicker than the others, which zip codes
Mhm.
are being hit more than the others.
Yeah.
And certainly after George Floyd's murder, um, which contributed to this awareness, but even before then, we knew. I mean, come on, who didn't know? I know as a
Mhm.
primary care internist, my patients, my practice has been in the medicine clinic in Presbyterian Hospital, which is where people who live in the neighborhood come. And
Mhm.
they can't afford going to the private doctor, so they come to the clinic. So I have cared for patients who are by definition poor,
Mhm.
many of them Dominican, which is our neighborhood in Washington Heights. And I know that their illnesses are in considerable part dictated by their poverty. I know that. I mean, we know that. It's not me. We know that. And when we look at, you pick it, nutritional status, heart disease, stress, mental health issues, obesity, um, diabetes, all of it is exacerbated in the context of inadequate food, inadequate income, um, the kinds of things that show up in poor neighborhoods that don't show up in rich neighborhoods, like toxic dumps, not even toxic, just ordinary dumps,
Yeah.
dumps. Um, the absence of park, the absence of safe place to walk, the absence of gyms that one can afford, all of this. And so when COVID came, who got it?
Right.
And of course, it became a black and brown disease because of the economic picture of this city, this borough, this country. Meanwhile, we are watching another pandemic of police violence.
Mhm.
And that one replicates the pandemic uh, uh, um, census. Meanwhile, we are watching a pandemic of carceral system outrage with the incarceration of persons, again, on transparently racial grounds. Yes? So all of this is in a cauldron of now what's going to happen.
So there's a way in which this has bubbled to the surface. I know that your colleague, Dr. Santanyani Dasgupta, has an article that she's published and also a series of talks that she's given with some medical students here at UNC, entitled Abolition
Abolition
Medicine.
medicine. Yes,
And
yes,
I'm wondering if you could talk a little bit about that work.
yes, yes, absolutely. Because the work we look, come on, the work we do in narrative matters is counter to injustice.
Yeah.
Social justice, anti-racism, um, 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 it's not only understanding the perspective of another, it is
Mhm.
understanding and owning up to the perspective of oneself. It is
Hmm.
understanding and owning up to um, whether it's white privilege or gender privilege or ableist privilege, all of these ways, professional privilege, all of these ways in which, I'm more likely not to get sick from COVID than some of the patients that come to my clinic, right?
Yeah.
We did a workshop on race and justice using narrative medicine methods. And, like usual, like 100 people came, and they came from all over. And 6 months after, we did a survey to say, like, what do you remember? What stuck? What has changed? And in fact, Sayantani was one of the lecturers, um, as was Topher Sanders, who's a Politico journalist, and George Yancey, who is a scholar, philosopher, anti-racist leader. And we read together complicated texts, from Baldwin to Euripides. And what happens in the small groups, as 8 or 10 people together are reading very charged texts about race, is that the white persons are able to hear the persons of color talking about the text and about the conversation, and the white people themselves come to their senses.
So I really hear you on this. And one of our listeners, Anne, has posted in our chat that she writes 728,000 of the 979,000 deaths were people over 65. She must be talking about in the US in particular. So it seems to me that we are we're hearing new voices, and
Good.
yet the issue of elder care, it seems to me, and transformations in elder care is not getting the same kind of attention. What are your thoughts about?
Well, I think we've been attuned to the frailty of the elderly. I think the whole field of geriatrics and gerontology, when they're well practiced anyway, has attuned us very much to the alterations in care that you have to do as a patient ages. Anne is absolutely right that the brunt of this fell on the older you are, the more likely it is that you have accumulated enough comorbidities or other diseases that you're less likely to do well.
So I might push back just a little. I actually read an article about this. And it seems that there is frailty, of course, but there is also endangerment. And it seems to me a health humanities perspective, a narrative medicine perspective, can observe the fact that our methods of congregate care are a serious problem.
Yes, sure.
And that's economic, right? Because of the pay for the caregivers, they have to work multiple jobs. So that is the kind of structural analysis.
That's absolutely right. And these long-term residence situations is where the appetite of this pandemic first came to be seen. Absolutely. And we all know that Medicare is not near able to cover the expenses of even a healthy older person. And so that too then has economic preferences.
Yeah.
And the richer you are, the better you do as you age. But I appreciate Anne's bringing this into the conversation, because look, it is, the pandemic is exposing underlying inequities and dangers. I talked about mental health for children. I talked about socioeconomic determinants. The age gap in a society that so values youth. You're over 30, you're old. And I can take some collective guilt that the illnesses or the conditions or the situations of older people probably do not get as much highfalutin scientific research as, rare forms of cancer do. So
Yes,
this is a social um, um, prejudice.
it seems to me also, Rita, the narratives that we circulate about what it means to be a clinician and a doctor in particular, um, they're fast-paced, they're exotic, there's a lot of sex involved, people get well after chest compressions, so on and so forth. We are not collectively telling a story
Yeah,
about fragility and the everydayness of
yeah,
care
yeah,
to our future doctors,
yeah.
nurses, practitioners.
Do you really think they're fooled by all of that?
They're quite, my medical students, I posed this to them last week, and they said, no, they don't want to be a surgeon because they saw a surgeon on TV. But the more they reflected, they did all agree that they wanted their work, like any human being, to be interesting, to be intellectually engaging, and so on.
Yeah,
Whereas so much of what we've learned about why people show up to the emergency room, it's not a kind of glamorous fascinoma. It is everyday problems.
yes, yes.
Um, uh, One thing I also want to put out there, we have another wonderful audience member, Marina. She says, I'd love to hear Dr. Charon talk about narrative medicine addressing upstream root causes
Mhm,
of health outcomes. She's a public health practitioner. She
mhm,
facilitates narrative medicine workshops. That's a
mhm.
great
Yeah,
question.
yeah, 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 yeah. So upstream meaning the kinds of things that you wish you could dam up before the flood comes. And again, I mean, some of the upstream things that we try to target are issues of food deserts,
Mhm.
um, um, fume releasing places like factories. Um, uh, Higher upstream are the economic divides.
Mhm.
You know, I mean, it's just obnoxious to be reading about these Russian oligarchs with they don't know what to do with all their billions. What about, I mean, we have a health wealth gap
Mhm.
that is murderous. So upstream is indeed the forms of economic life.
Yeah.
It is certainly the forms of governance of healthcare delivery systems.
Yeah.
Um, if you could do one thing to improve the vitality and life and healing power of all our nurses, doctors, and social workers, it would be to increase the time of each clinic visit or encounter from the current 9 to 12 minutes
Yeah.
up to 30 minutes. Every patient gets a half hour with you. See?
Yeah. In terms of the crisis in time, which is one of our themes, it's hard to get past the fact of a 15 or 20-minute appointment with people with multiple problems caused by inequities built into the system.
Wow. And if we look at other countries, in Korea, the time can go down to like 2 or 3 minutes.
Yeah.
And so what does that mean? People have to come 10 different times to the doctor to
Mhm.
take care of one thing. Or they do the quickest thing. I mean, it's just so counter. If Marina is a public health professional, she knows this very well. That the 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 delivery system that cranks people through at this pace, oftentimes not preserving even the identity of the
Mhm.
person taking care of them, so that there's less and less occurrence that, oh, I know who you are,
Yes.
you know? And patients for decades have been lamenting about the fragmentation, the impersonal nature. They say, nobody knows me.
Yeah.
Nobody knows me. And we know, Jane, as literary scholars, we know the convolutions and the depth and the nuance of the relation. Um, I mean, the reason that there is a health humanities to begin with is that there needs to be some recognition
Mm-hmm.
in care, recognition
Yeah.
that attention needs to be paid, right? With
Given the
conversation.
intractability, seeming intractability of some of these questions, we have a good question from an audience member. What has or will the pandemic, what has it done or what will it do to the writing and teaching of literature? So in some ways, how can literature, help address systemic
Well,
problems of a capitalist system?
yeah.
On the other hand, I know you have an answer for us.
One of the novels I read during this period was Harrow
Mm,
by Joy Williams. Anybody read it? It was indeed
I have
harrowing.
not. Mhm,
And it was a very flat painting of the end of life.
mm,
Some unnamed disaster had happened. Everybody knew it. Nothing was going to survive. Very flat, chilling.
mhm,
At the same time, I happened to be reading poetry by Jory Graham,
mhm.
which is similarly um, illuminating the end of life.
Yeah.
So this is what our literature gave us.
Mm,
I think it was brilliant. It was damned hard to read,
mm,
but it gave us a accurate, affective
mhm.
position from which to not view the pandemic, but view our own lives within it. And it was in reading Graham's poems and Joy Williams Harrow that I'm like, okay, this could be the end. This could
Yeah,
be the end. I think we're all saying that even more with what is happening in Ukraine.
yeah, yeah. I'm
This
glad
could,
you brought that up.
this could be the end.
So I do want to mention that one of our listeners has put in the chat that Transplant is a wonderful Canadian series that has the ER drama, but also includes the discourse about PTSD and the grind of medical practice in its
Mhm.
Syrian refugee main
Ah,
character.
good, good.
So I do think,
Transplant.
yeah, Transplant. I also want to recommend A Young Doctor's Notebook, which is a very strange, oddly comedic television series that ran a few
Oh,
years back. And it's based on Chekhov, but it has Daniel Radcliffe and John Hamm playing the same character. And it's a
oh,
wonderful example of
oh, neat.
burnout and its consequences with a darkly comedic angle.
Okay.
So narrative medicine, we can hear from you, Rita Charon, that it emerged out of your commitment to the humanities, to clinical care, and frankly, to a certain understanding of social activism and justice. We
Mm.
hear that. Where I understand you've been involved in a strategic planning process with your team,
Mm-hmm.
what does the next iteration of
Mm.
narrative medicine look
Oh,
like? Where are you going?
yeah. We we are growing. We are growing internally and externally. Our Narrative Medicine International is now across the globe. Um, we have been cultivating, growing our own master's graduates and doing lots of, we call it continuing narrative education. I mean, you got to, and so we are asking ourselves, you know, here are the things that we need to do. We don't even know which ones to start with, and I think we're just starting with them all. We need to really intensify the kinds of outcomes research we're doing because we still don't have adequately sized studies to
Mhm.
say to skeptics, um, doing narrative medicine work with patients or with clinicians improves health.
Yeah.
And we have glimpses of that, but I, as a physician, know how other physicians and scientists uh,
Mhm.
handle data, and qualitative data all by itself does not do very much. So that I mean, I'm hiring health services researchers to work with us to develop really rigorous, well-documented, well-designed studies to show what is it that emerges as a consequence. It may not be what we think. There
Mhm.
may be consequences that we don't know to be following. So it's
Mhm.
kind of very basic research. Um, we one of the things we're wondering, you can help me with this. We have a lot of people with a master's degree in narrative medicine.
Mhm.
We have another certificate program, and that's kind of more for clinicians who are eager to do this kind of work in their practice. Um, Many have asked us, when are you going to start a PhD in narrative
Mhm.
medicine? I used to say, that's crazy. If you want to learn what we need to know for narrative medicine, go get a PhD in English or philosophy or anthropology.
Mhm.
The better we get at this, the more I'm actually attuned to the idea that this is a field,
Mhm.
that it is a discipline. We have very distinct methods. So I think that's not unusual.
Yeah.
Um, do we need to start a nonprofit, a 501(c)(3), in order to amass some money and then give grants to other people?
Mhm.
See, I mean, it's how can we expand the work being done in this field? And I do, in our very end here, have to distinguish a little between narrative medicine and health humanities
Mhm.
because
Please.
we're kind of a subset, a subdiscipline, and there are a lot of things that people call narrative medicine that ought more typically be called like arts and health or something like that. Um, and we feel very um, committed to having intellectual foundations to this work. It is
Mhm.
not, oh, give the kids a break from biochemistry, give them some poems. It's not that. It's a rigorous foundation in literary theory and phenomenology and narratology and creative fields. And social justice and advocacy are very much part of that foundation. So that,
Thank you for that encapsulation because we need that. We yearn for it. So beautiful and eloquent. A listener named Mary writes, do you think that the pandemic has increased awareness about the importance of the humanities in medicine and medical education? I would add to that, Rita, in your time, have you seen more medical programs changing and incorporating narrative medicine as opposed to counting on you at Columbia or us at UNC to
yeah,
do that work?
yeah. No, absolutely. I mean, we look at places we're being asked to give talks and do consultations. And there are places, I was at University of Kentucky a little while ago. And I've got several colleagues at the University of Utah. I
Mhm.
mean, there's places where there are not active programs already on the ground. Um, I think the pandemic really intensified this movement, as I said, with our Zooms. What could we do to reduce
Mhm.
social isolation? We're going to read together. We're going to make community. we got hired, if you will, invited to a group of clinicians on a tiny island off the coast of British Columbia, which is home to a particular First Nations tribe.
Mm.
And they didn't have access to the ferries that used to go back and forth. So they were really very isolated. And they called us and said, please, can you give us our own narrative medicine sessions? So we did. And two of our guys kind of did a special Zoom for this small group of clinicians.
Great.
And it kept them going
Mhm.
as a unit. It kept them going. So
Incredible interpersonal thinking, which is enriching and meaningful. And I love that narrative medicine is attentive to the needs of clinicians. It's not just the clinician-patient dyad, but clinicians as a population.
oh, absolutely.
So Elizabeth writes, can you talk about the role of narrative in exploring ambiguity in healthcare? Beautiful question.
Yes. Well, it is indeed a narrative and literature and painting and symphonies, all of the humanities and the arts. That's what they're for. That's what they're for. It's for knowing that your particular expectation is just one among many. And the reason that we do our work in groups is so that no one person feels they have a corner on what this means. And I mean, I'm sure you've seen, Jane. You bring a poem, you bring a painting, you bring a sculpture, you bring a graphic novel frame to 8 people,
Mhm.
and not only, I mean, it's a trite to say they each have a different idea about what it is, but the power of it is that each of those 8 leave with 8 versions of what it is.
Mhm.
And they come to understand with some humility that that their idea is neither the only nor the best. And furthermore, we just did a very complex poem by Donica Kelly, who's an astonishing new poet.
Mhm.
And it was very hard. We went through it like very, very close reading. And I had to keep interrupting the discussion to say, do you see how it took each one of us to be in this room to understand this?
Mhm.
That we couldn't have done it just with 7 people. We couldn't have done it just with 6. And it had to be these particular 8. So doesn't it, Jane? It just kind of taps into the I don't know, the deepest kind of knowing and
Mhm.
seeing and intuiting and hearing. Um, and then that all gets kind of amassed into what this group now knows. And they
Well,
know.
yeah, one thing that you do in narrative medicine is you bring the concept of practice to the humanities and to literary study. You call attention to what we as literary and historical scholars do, the way we think textually, the way we interpret language, the
Yes.
way we have to place any individual work of art within its broader context to understand its meanings and its repercussions. So you, with narrative medicine, fertilize and enhance literary study. It has been my experience.
Yeah. It's funny. One of the projects I'm doing now in Columbia is interviewing a group of our very accomplished scientists. And I get to do these long interviews and tape record them and transcribe them and then go back to them and really. And what I'm tuning into is their creative process. And so I'm looking at the obverse of what you just asked. It's the creativity and the capacity to tolerate the ambiguity and to value the ambiguity that makes for great science.
Mhm. Mhm.
And when I ask myself the question, what is the scientist's work of art. If the painting is the artist's work of art, the scientist's work of art is not the finding,
Mm,
not the conclusion, it's the hypothesis.
mm, mm.
Got it?
The imagination within constraints of evidence, theory, and observation, something like that.
And it's the capacity to ask a really great question.
Ask a good question. Yeah.
That's Suzanne Langer, that's Alfred North Whitehead, the capacity to ask. So that's what I'm finding in my creative scientist. Now you're turning it around and saying, what is it that the scientist or clinician can bring to literary scholar? I think it's kind of parallel
Mm-hmm.
or mirroring that we're very good about saying, well, how does it work?
Mm-hmm.
That's all I do all day. How does it work? What's the pancreas doing?
Yeah.
That releases insulin. And what, God help me, is the insulin doing once it hits a liver cell?
Mm-hmm.
So, in a funny way, it's my mechanistic brain that has made me a narratologist.
It's great though. How does this poem work? This short story is having certain effects. Edgar Allan Poe, The Telltale Heart. How's it working on us? How is he tuning our nerve endings?
Exactly.
Yeah.
Yeah. See? See?
So I have a question for you. I'm happy to say this question comes from Thailand, and it in fact comes from an old graduate student of mine. She writes, we don't have small questions here, Rita. How should we respond when we are confronted with the reality that capitalism often expects us to expose ourselves to health risks for the sake of being productive?
Mm-hmm.
Has the pandemic showed us how impossible it can be to prioritize our own safety when it interferes with our labor?
Yeah. You know, we're all going to start reading Marx again.
Mm-hmm.
I mean, they're really questions of labor and surplus labor.
Mm-hmm.
You remember that surplus labor equals profit, right? So thank you for the question from Thailand. I rather delicately said like a half hour ago something about upstream factors and the wealth health gap and how it is that health delivery systems are set up, and the fact that revenue boosting is one of the goals
Yeah.
of the healthcare delivery system. I did not say very much about pharmaceutical industry or device manufacturing or how all of that works. But um, what's happening now in Ukraine is asking a question about capitalism, isn't it?
Yeah.
This is not the question that we hoped capitalism would be facing.
Mm-hmm.
Because in this situation, capitalism becomes kind of a shadow proxy for something others call democracy, right?
Mm-hmm.
But don't be fooled about what is going on in that conflagration. I think the question from Thailand is indeed about revolution. It's about rising up. Um, you know, the Amazon workers at Staten Island
Mm-hmm.
became unionized. Did you know that? Staten Island,
Mm-hmm.
which is a very kind of reactionary type borough. But if Amazon is forced to deal with labor unions,
Mm-hmm.
isn't that a good sign? Right? So, but I mean, I wish I could hear other answers from others of you
I
out
know.
there. Indeed,
Mhm.
isn't it a question of the deepest forms of government? And if we're now hedging and saying, well, we're in an inflation now, and is it inevitable that a recession comes? And you say, well, what is a recession? A recession is when the consumers don't have enough demand for products, and so there's a slowing down of the whole economic process. All of that leaves untouched the questions of how this system works.
Mm-hmm. Getting back to your question, how does it work? So I just want to say to the audience, we would love to hear your questions. We have interjected a few of your questions along the way, but Dr. Rita Charon would welcome your insights, your wisdom, and your questions. What do you think is the role of the humanities moving forward? Do you think that medicine, widely construed, healthcare, now understands the importance of the humanities? How would you evaluate, if you will, the state of the field, the state of higher education?
No, they don't understand what it is. The younger you are, the better you understand it.
Mm-hmm.
Certainly the students, and one of the things I do at Columbia is to organize this interprofessional education group, so that we're working with 10 different health professionals, including the ones you imagine, doctors, nurses, dentists, but also social workers, chaplains, genetic counselors, nutritionists. And that is one of the most productive areas for our efforts to rehabilitate medicine, to rehabilitate health care, to reduce some of the hierarchical nonsense that goes on, where if something is going on, if there's a team together, it's the doctor who's the inevitable leader. No. And our students learn, to say, well, what do the nurse think we should do? Where's our public health professional? What should we be asking here? And they develop a reliance on one another, which I think is great. Do the upper echelons of does organized medicine, the AMA and stuff like that? They think it might be a good way to make sure that their doctors don't retire early or leave for other jobs, things like that.
I love this fact that you're emphasizing the cultural and societal power right now of nurses, perhaps in particular, also physicians, in thinking from the middle about how to restructure our healthcare system.
Well, yeah, it's kind of on the fly you're on the fly trying to, change the direction of the river.
Yeah, right, while you're in the stream. So Jody writes to us, Rita, you emphasize that much of a patient's story can be unspoken or implied through body language and small facial expressions. Telemedicine has been crucial, but what barriers have you found, and do you think there are, to narrative medicine enriched practice given the video conferencing?
Oh, well, it's a useful gadget, but let's hope it doesn't replace actually being in one another's presence.
Yeah,
we are embodied. We are embodied. I taking care of you, we are both embodied. And that which I come to know about you, I know through the workings of my body, and that which you're able to tell me, including where it hurts, is by virtue of your body. We're very good phenomenologists. We agree with Merleau-Ponty that our contact with the world is inevitably and only through our bodies. So telehealth doesn't please Maurice Merleau-Ponty.
Mhm, mhm.
He would die. He would not be happy were he still alive to see this. So I certainly hope it doesn't replace. But of course, again, going back to the Thailand question, it's cheaper, isn't it? Because doctors don't have to, travel to get into work, and you really can have somebody in the room every 15 minutes because they don't have to walk in from the waiting room and take their coat off and
Yes.
things like that, right? So it's um, money saving.
Yeah.
And I think whoever asked that question, Jody, I think you said,
Mhm.
um, is wise to be noticing that some powers that be might want to keep it that way. Um,
So another question for you from Tessa. How do you imagine that arts in health and medical humanities can work together to shift clinical perspectives? And Tessa asks this partly as an arts health practitioner herself. She points out that she and the profession have their own set of rigorous foundations, and yet they face skepticism.
yes, yes. I wrote a piece in the Lancet not long ago called Knowing, Seeing, and Telling,
Mm,
arguing that instead of dividing the arts from from science, we can appreciate that practitioners on both sides of that divide each have their own epistemology in knowing, their own aesthetics in
mhm,
seeing, and their own narrative um, um, processes in telling. And that each of us has our own, thank you very much, very well worked out epistemologies and aesthetics and narrative methods. And it's not as if the sciences are the only ones with epistemologies. And it's not that the artists are the only ones with aesthetics.
mhm.
Do you see? But certainly, Tessa or Tessie hit it on the nail on the head because we have real accomplished disciplinary rigor in the work we do,
Mhm.
and it's almost how can I say it's belittling to even have to say that. But any PhD student in a humanities department knows that it's not easy.
It's not easy. And here's the question that tags on to this. How might you distinguish narrative medicine from other applied disciplines to caregiving, such as psychoanalysis? What, what makes narrative medicine unique and more or less effective than others?
I'm not making racetracks here.
Right.
I'm not trying to put psychoanalysts out of business. Heaven forbid. This is like um, philosophy, history, anthropology, linguistics. It's not like one is going to gobble the others up.
Mhm,
So there are many disciplines. There is a thing called narrative therapy,
mhm,
which is the complete clinical arm of this work. Um, the medical anthropologist uses a lot of the same methods we do. We both do qualitative interviewing. We do a lot of work with the oral history group
mhm,
who shares a lot of what we do. More and more, we're working with photographers. We're working with theater companies. We're working with dance companies. Our students our students study with the Mark Morris dance company. So so we are, if anything, we are uh, um, ravenous
Mm,
for that which we can learn from others, borrow from others, partner with others.
mhm.
And I think it's kind of, and this is true of the health humanities as a whole, I think it's very impressive that social workers, doctors, nurses, dentists are searching us out.
Mhm.
You know, I just got a call from the head of the neurology department. Say, Rita, can you come, meet with our residents like once a month, like do what you do? And it's like, sure, Richard, you know, um, if they have an urging or a thirst for this kind of work, and they don't all know exactly what this is, um, that's sign of great growth, don't you think?
Absolutely. Yes.
And when we got a call from the ophthalmologist,
Mhm.
we're saying, okay, you know, because, family physicians, palliative care doctors, general internists, we understand what it means to listen to stories, but ophthalmologists? So that,
So I have to point out that even as all of the medical fields are reaching out to you, there's a way in which the humanities can face disparagement by bean counters in state
ah,
houses. This
mhm.
is something we're familiar with at UNC. Um, so here's another question
Yeah.
for you. Is it possible, writes, I think this is Sebastiano. Yeah, Sebastiano writes, is it possible that humanities and narrative medicine could lead to a more balanced relationship between the cost of healthcare and the quality of care received?
Between the cost of healthcare and the
And the
quality,
quality of the care, yeah.
meaning that the more you pay for it, the better it should be?
What I intuit is in there is perhaps a sense that we could lower a lot of the biomedical interventions if we have
Ah,
clinicians who are more versed in a
oh, okay.
whole set of tools when it
Yeah.
comes to understanding the needs and caring for patients.
Well,
That's my guess.
that that's a very important connection. Um,
Um, Rita, I'm sorry. I think I'm interrupting my own question for you, but we have just a couple minutes left. And I do want to take a page from the New York Times' Ezra Klein and ask you, Rita
yeah.
Charon, what books have captured your attention? Let's say 3 books that have captured your attention that are pertinent to our conversation today about narrative medicine and the humanities in healthcare. What would you recommend to people listening on this call?
The last three I've read, the most recent one that I think everyone needs to read is by Donald Antrim.
Mm,
It's
mm,
called One Friday in April, and it's a story about his suicide. It's a very challenging story. He came and read at our narrative medicine rounds. Um, and he says, no, he's
mm,
not depressed. He has suicide,
mm,
which means he has lived all his life with a desire to die. This was, I talked about harrowing before. This
mm,
was even more
mhm,
harrowing
yeah,
because it raised the specter of a life being lived in protest.
mhm, mm.
The writing is exquisite. Um, you know what the last big novel I read? Ulysses.
Oh, beautiful.
And my team at Narrative Medicine read it together. It was great. Like it took us 2 seasons,
Mhm,
and we read the entirety. Um, a novel I want to bring to your attention is by Tokarczuk,
hmm,
Olga Tokarczuk. She got the Nobel in Literature a couple of years ago. Um, the Her earlier book is called Primeval.
mhm,
It's an exquisite, complex study of the passage of time.
Hmm.
She has another book coming out, the Book of Jesse, which is 1,000 pages long. But Primeval is an extraordinary book. So I gave you three: Donald Anthrop, Tokarczuk, and Ulysses.
What a wonderful trio for us to contemplate reading and perhaps bring our attention to. Before we close, I want to say a huge thank you to Dr. Rita Charon, who continues to do amazing work and brings together the humanities and healthcare in an essential way. I want to let you know too that our conference from the National Humanities Center will continue this entire week. Tomorrow is a banner day. We have sessions at 1 p.m., 3 p.m., and 7 p.m.
Wow.
Ula Biss, the author, is among our panelists. So please stay tuned. And thank you to everyone who turned out for this wonderful talk with Rita Charon.
Thank you all.
Good night.